Hey there, welcome back to the Medcurity podcast. Today we are talking about one of the most important but often misunderstood phrases of HIPAA, reasonable and appropriate. Now this isn't just vague legal language, it is a standard that shapes how healthcare organizations secure patient data. And in 2025, the expectations behind that phrase have changed. So what does reasonable and appropriate actually mean today? That's what we're unpacking. Whether you are a compliance officer, an IT manager, a clinic administrator, or wearing all three of those hats, the episode is designed to help you understand how to meet today's standards and how to avoid the kind of mistakes that lead to investigations and fines. Let's start with some background. HIPAA's security rule has always been scalable. Now this means it is built to flex depending on the size, complexity, and capabilities of your organization. A two-person clinic in a rural town isn't expected to implement the same exact safeguards as a multi-state health system. The language intentionally avoids rigid checklists and instead uses terms like reasonable and appropriate. But here's the catch. With that flexibility still being there, enforcement trends show that the OCR is interpreting reasonable with far less leniency, especially when it comes to repeat issues like outdated software, weak access controls, or an incomplete security risk analysis. So what's changing? Well, in the past, many organizations relied on basic compliance checklists. You had a policy, great. You listed a risk in your SRA, check. But now regulators want to see what you've actually done with that. The biggest shift in 2025 is this. Documentation alone is no longer enough. OCR expects organizations to identify real-world risks, take action to address them, and keep that process active. For example, if your security risk analysis shows that multiple users still have access to PHI after leaving the organization, it's not enough to just acknowledge that. You need to show how you are fixing the problem, whether that is updating your access review procedures, using an automated termination system, or training managers on proper offboarding. Let's move into how this applies to core HIPAA safeguards, the administrative, physical, and technical. Administrative safeguards include things like your risk analysis, risk management process, policies, workforce training. To be reasonable and appropriate today, the OCR expects your SRA to be current, not from 3 years ago. Risk management needs to be an actual process, not just a document. Your training program should be more than a checkbox. It should reflect current threats, like phishing or mobile device risks. Physical safeguards involve controlling physical access to systems and devices. If your facility has shared workstations, you should be logging off sessions and securing devices after hours. If lost or stolen devices have been an issue in your environment or your region, encryption on laptops and mobile devices is likely no longer optional. It's expected. And technical safeguards cover access controls, audit logging, encryption, and transmission security. Using shared logins, that's not reasonable in 2025. Not reviewing audit logs regularly, that's going to be a problem in an investigation. OCR is expecting access controls to be individualized, roles clearly defined, and activity reviewed regularly. Now, let's look at how this shows up in enforcement. In 2023 and 2024, several enforcement actions highlighted exactly where organizations fell short. For instance, Comstar was fined $100,000 in 2023 after OCR found that they never conducted a complete risk analysis. In another case, a healthcare group was penalized for failing to implement sufficient access controls. Employees were accessing PHI long after they had left the organization. More recently, in early 2025, Warby Parker was fined $1.5 million after a breach exposed the electronic protected health information of nearly 200,000 individuals. OCR's investigation revealed that Warby Parker failed to implement sufficient security measures to guard against unauthorized access, violations that could have been identified and addressed through a thorough and up-to-date risk analysis. In each case, the core issue was the same. The risk was either unrecognized or unaddressed. And that's the pattern we're seeing. It's not just the presence of risk, it's the failure to act on it that is drawing these fines. So let's talk about what practical steps you can take. Start with your security risk analysis. If it hasn't been updated in the last year, or if it was more of a template fill in the blanks than an actual review, it's time to revisit it. Look at your EHR systems, mobile devices, email platforms, vendor relationships, and your staff workflows. What could go wrong? What has gone wrong? Then build or update your risk management plan. Prioritize the issues you found, assign owners, and set realistic timelines. If you found that you are still using outdated Windows versions, include a timeline for decommissioning. If your staff reuses passwords, outline a transition to multi-factor authentication. Vendor management is another key area here. Are you evaluating the risk of your business associates before sharing PHI? Do you have a business associate agreement in place? Are you reviewing their safeguards or at least asking for evidence that they exist? And access controls, again, this one is big. Are you removing access immediately when someone leaves? Are you tracking who has remote access to PHI? These are low-hanging fruit in audits. If the OCR sees lingering access from past employees or shared logins or remote access with no tracking, they're going to flag it. Training is another area that is coming under scrutiny. It's not enough to say, oh yeah, we train our staff. OCR wants to see what the training includes and how often it happens. Do your employees know how to recognize phishing emails? Do they understand how to report a lost device? Are you training on emerging risks? Here's a useful way to think about it. Ask yourself, if we had an audit tomorrow, could we show that our safeguards match the size, scope, and complexity of our organization? Could we prove that our risk analysis is recent and that we are actively responding to findings? Let's take a moment to walk through a simple comparison. Here is a bare minimum approach. You did an SRA in 2021 and you haven't touched it since. You list password weaknesses in your findings, but you haven't changed anything. Training is offered during onboarding, but never again. And you assume vendors are secure, but you don't ask for proof. All right, now here's what a reasonable and appropriate approach might look like in 2025. You review and update your SRA annually with documentation of changes. You require multi-factor authentication and you train your staff on password hygiene. You run phishing simulations twice a year. You evaluate vendors before signing a contract and you review them annually. And you terminate system access within 24 hours of someone leaving. Same HIPAA rule, very different outcomes. Before we wrap up, let's look at what is next. OCR has signaled through recent enforcement actions and statements that audits will continue to focus on SRAs, vendor oversight, and employee access. There's also talk of an updated HIPAA security rule guidance and possibly a finalized NPRM that could add more specificity. Plus, with AI tools, ransomware threats, and cloud-based EHRs becoming more common, what's considered reasonable will likely continue to evolve. In other words, this isn't static. What's reasonable today might not be enough next year. That's why regular reviews, smart documentation, and clear follow-through are your best strategy. Thanks for joining us today. If you're not sure where your organization stands, start with your security risk analysis. Don't wait for an investigation to find out that you missed something. If you want help with your SRA or with any other compliance efforts, our team at Medcurity can help. Until next time, stay safe, stay compliant, and keep protecting that patient data.